Okay, guys, so we're going to start with diabetes mellitus. So it says diabetes mellitus. Let me make sure I'm sharing. Yes. Diabetes mellitus is a pancreatic disorder resulting in insufficient or lack of insulin production, leading to elevated blood sugar. So what's happening in diabetes mellitus? I'm sorry, guys, my allergies are acting up. The patient's blood sugar is getting too high, and it could be due to the pancreas not working. Remember, guys, that islet cells and the beta cells in the islets of Langerhans of the pancreas, that's what produces insulin. So if the patient has type 1 diabetes and that pancreas is either not working or it's not working effectively, it's not working enough to make enough insulin for that patient to survive, they're going to be diabetic. So that's one. Another thing can be patients been diabetic, their blood sugar's been high for so long that their body has given up. The pancreas is like, you know what? I'm still going to make insulin, but the insulin that I'm making is not going to be sufficient to bring down all of this blood sugar, right? The body becomes resistant to that insulin that pancreas is creating, right? And that's your type 2. So there's two types of diabetes, type 1, type 2. Type 1, we tend to see this in children. It used to be called juvenile onset diabetes, and that's when either the pancreas wasn't working or it wasn't working sufficiently. And then you have type 2 diabetes, and we often see this where the patient just has insulin resistance. They're making insulin, the body's just not resistant to it, okay? So anyway, type 1, insulin dependent, I'm right here. It says immune disorder, and it is an immune disorder. Whenever you see immune disorder, I want you to think of the body just attacking itself. The body, the person's own body is what's causing the problem. Immune disorder, the body attacks insulin producing beta cells. Remember, guys, those beta cells are in the islets of Langerhans, that is in the pancreas. So it attacks insulin producing beta cells, resulting in ketosis. Result of ketones in blood due to glucogenesis from fat. So here's what happens. Let me explain this to you guys. Your tissues, every single cell, they need energy. What does it get the energy from? The glucose. But guess what? If the patient has type 1 diabetes, their pancreas is either not making enough insulin or they're not making any insulin, period. Guess what? That insulin is the key to get the sugar out of the blood and to the tissues where it belongs. So this patient that has type 1 diabetes, they don't have the key, which is the insulin. They don't have the key to get that sugar out of the bloodstream because that sugar is not doing anything for that patient in the bloodstream except making them sick. That sugar needs to be in the tissues where the tissues can use it for energy. Well, in the meantime, while that sugar is stuck in the blood, the tissues are screaming, help, help, we're dying, we need to feed off something. So what does the sugar start to feed off? The sugar starts to feed off of the body's own fat. And guess what? The byproduct, so it starts to feed on the body's own fat, the body's own muscles. The byproduct is ketones, and that's why we end up seeing ketones in the urine, and we're not supposed to see that because the body's not supposed to be feeding off of the patient's fat and the patient's muscles. It's supposed to be feeding off of the sugar, but it can't get the sugar because the key to getting the sugar, which is the insulin, the body doesn't have it, okay? That's your type 1. Now you have type 2, insulin resistance. The beta cells don't produce enough insulin, or they do produce enough insulin and the body's just resistant to it. That's your type 2. Something I want to point out to you because it's very important in NCLEX that you know this. It appears a lot. You need to understand that the majority, about 90% of patients who are type 2 diabetics don't have to be type 2 diabetics. And I mean that this is reversible. This is not an irreversible disorder. If you're type 1, there's nothing you can do about it. It's irreversible. It is what it is. But 90% of those patients who are type 2, it's reversible, which means that, what's the word I'm looking for? Give me a second, guys. Let me sip on my coffee. Maybe I'll start thinking. The word I'm looking for will come to me. But, you don't have to have that type 2, which means if the patient starts eating right and exercising, it can be reversed and they won't be a diabetic anymore. And NCLEX is very big on that because they're very big on teaching. Let's look at NCLEX points. Assessment, 3 Ps, your polyuria, polydipsia, polyphagia. You're going to see this in these patients who are diabetic and their blood sugar is extremely high. And let me explain this to you, because guys, you cannot memorize. You have to understand. Because if you can understand why this is happening, no matter how the questions flip to you, you'll be able to answer it. So polyuria, that's excessive urination. Remember, all of the sugar is in the blood, but it's supposed to be feeding the tissues. So your body's trying to survive no matter what. Your body's trying to bring the sugar level down. So you're going to have excessive urination because the body's trying to get rid of the glucose through the urine. So the patient's going to keep going to the bathroom because the body's trying to get rid of that glucose. Polydipsia, that is extreme thirst. The body is trying to dilute that urine. So the patient's drinking water, trying to dilute and get rid of all that try to get rid of all that sugar in the blood. So they're going to want to drink lots of water. Polyphagia, excessive hunger. Do you recall that I told you that, sorry, plane is flying over. Do you recall that when I told you that when all of that sugar is stuck in the blood, the tissues can't feed on anything, so they start feeding on the patient's own fat, then muscles. So what happens with that excessive hunger, that's the tissue saying, I'm dying, feed me. And so the patient will have hunger and they're eating more food. But guess what? That sugar is still locked in the bloodstream, because what's the key to get out of the blood into the tissues? Insulin. So that is a classic triage of symptoms for a patient that's going through hyperglycemia. Polyuria, polydipsia, polyphagia. Make sure you know it. I promise you'll see it again. Other assessments that you're going to see in this patient, you're going to see elevated blood sugar. You're going to see blurred vision. And I want you to think about it, guys. Remember, I told you this sugar is stuck in your bloodstream, right? You know that you have tiny vessels in your eyeballs, right? How's the tissues in your eyeballs going to be fed? Through those vessels. So imagine sugar being stuck in the bloodstream, trying to get through those tiny little vessels in the eyeball. Think of sugar as like syrup. It's thick as syrup, as molasses. Can you imagine that being in the blood, trying to get through those vessels in your eyeballs? Of course, you're going to have difficulty seeing. Absolutely. Blurred vision. Elevated hemoglobin A1C. The hemoglobin A1C, guys, for a normal patient, we want it less than 5.7. If the patient's diabetic, we want it less than 7.5. Some books say 7, but most say 7.5. Or 7. Look at your textbook, but I promise for NCLEX is going to be way out of range, okay? So the hemoglobin A1C gives you a picture of what that patient's blood sugars look like for the past 90 days, for the past 3 months. And the hemoglobin A1C, so in a wonderful assessment tool with that hemoglobin A1C, the patient can't trick you. They come in to get their blood checked. Well, yeah, maybe they had a light dinner and they just had a salad for dinner and they only drank water the next day, right? And so the blood sugar may be good, but that hemoglobin A1C, it tells us the truth. It tells us how compliant that patient's been with their diet, with their exercise, because it shows us what that patient's blood sugar has looked like for the past 90 days. And please don't forget, for non-diabetic patients, we want that hemoglobin A1C to be less than what? 5.7. Remember, it's always better, easier, healthier to prevent than to treat. Poor wound healing. Yes, the patient's going to have poor wound healing. Why? Remember, when you have a wound anywhere, wherever that tissue is in your body that you have the wound, how does that wound heal? By oxygenated blood, by vitamins, nutrients, minerals that are in the blood. Well, this patient has all this sugar clogging the blood. How's that oxygen, vitamin, minerals, nutrients going to get to the tissue? That's number one. And number two, with all of that sugar being in the blood, guess what loves sugar? Guess what loves wet, sugary, dark environments? Bacteria. So that is going to be a perfect medium for bacteria to grow, and that's why when it comes to diabetic patients, we're so concerned with patients being hyperglycemic. Hold on one second, guys. Okay. I thought my husband was trying to get my attention. Yeah, hyperglycemia, that's a perfect medium for bacteria to grow. So yes, they're going to have poor wound healing. They're going to have a neuropathy where they cannot feel, or maybe they can feel, but the feeling is very minimal in their extremities. And why is that dangerous? Because they might step on a nail or something that'll cut their skin open and they have no idea. They had no idea. So now that opening, which is a perfect medium for pathogens to get in, is now it's festering. It becomes infected. And before you know it, that patient's got to get an extremity or toe cut off, right? End organ damage. I'm right here. End organ damage is a major concern due to damage to the vessels. Think of that sugar that is thick as honey flowing through the entire the vessels of the entire body, going through every single organ. So of course every single organ is going to be damaged. Absolutely. Scroll down. Patients will have coronary artery disease. Remember guys, those coronary arteries, those are what actually feeds the heart muscles. So just like our regular arteries feeds our tissues, the coronary arteries feeds the actual heart, right? So what happens is, you know, patient can have hypertension, they can have stroke, all types of heart disease from diabetes, retinopathy. Again, remember, think about all of that thick sugar in the blood trying to get through those tiny vessels in your eyeballs. Absolutely, the patient can have a retinopathy, right? And diabetes is the leading cause of blindness here in the US, guys. Very important for you guys to know. So therapeutic management, let's talk therapeutic management. Let's talk about insulin. Required for type 1 and type 2 when diet and exercise do not control blood sugar. So let me tell you something. If that patient's a type 1, they're going to have insulin. That's why it's called insulin dependent diabetes, because they'll die without that insulin. They will have to get an exogenous source of insulin. What do I mean when I say exogenous source? I mean a source from the outside. Endogenous source, endo is from within. They're not producing enough. That's why they have to get an exogenous source, a source from the outside. They have to get insulin, okay? Now your type 2s, if it's caught early enough, right? The patient may just need diet, exercise. And then if that doesn't work, usually what the doctor will do is put them on an oral hypoglycemic along with diet and exercise. And then if that doesn't work, then they got to go on insulin, okay? You're going to assess for, I'm right here, you're going to assess for and teach the patient regarding peak action time for various insulin. Super important. I'm going to get into that with you in a moment, but something I need you guys to understand, because you guys tend to get this confused, and I'm going to clear it up for you. Let me take a sip of my coffee. By the way, not too many, but every once in a while I'll get a comment in my sections telling me that I'm unprofessional or I'm rude for drinking coffee while I'm making these videos. Number one, if it was not for these coffee, you wouldn't have any videos to be watching. So if it's a problem, I have no problem. Guess what? Go watch somebody else's video. It is what it is, guys. I have to have this coffee. I'm going to stay up to make these videos for you and to be thinking clearly. I don't know what to tell you. All right. So let's talk about peak time. What do you think of when you think of a peak? You think of elevation, something high, right? True. But the peak time of insulin, this is where you guys get confused. You think that's when the insulin is high because you think of peak. Peak means high. The peak of insulin means when the insulin's working the best. What does insulin do? It lowers blood sugar. So the peak of insulin is when you expect that patient's blood sugar to be the lowest. That is the most dangerous time, because what will kill a patient faster? Hyperglycemia or hypoglycemia? Hypoglycemia. So whenever you think of the peak of insulin, I want you to think of that patient's blood sugar being the lowest, okay? Only administer short-acting insulins IV. That's very important. You know, if you're giving an IV, you're only giving short-acting insulin. Do not use vial that appears cloudy. The only insulin that is ever cloudy is NPH. That's the only one. Any of the other insulins, if it's cloudy, do not use that vial. Throw it out. It's not good. Okay? Patients should monitor blood sugar before, during, and after exercise. Absolutely. And let me explain this to you. They're going to take their blood sugar before exercise because they're about to work out and they take their blood sugar and their blood sugar is 60. Do you think it's a good idea for that patient to work out? Absolutely not. The blood sugar is supposed to be 70 to 110, right? So it doesn't make sense for them to go ahead and work out if that blood sugar is 60. All it's going to do is drop their sugar even lower. And again, what is more dangerous, hyperglycemia or hypoglycemia? Hypoglycemia. So that's why they're going to check before. They're going to check during because exercise will, exercise will lower the blood sugar, and the patient wants to make sure that they're not getting too close to being low so that they don't bottom out. And of course, after, because the patient will need to know sometimes, you know, they're getting too close to bottoming out, their blood sugar might be getting too low, and they need to take a snack. The patient should use protective footwear to prevent injury. Absolutely. Why? Because remember, one of those assessments that we'll do in the patient that we often find in the diabetic patient is neuropathy, right? They lose that feeling in the lower extremity, or they may have a prickly feeling in that lower extremity. So foot care is very important. We want to prevent injury. So let me talk to you about some important things about foot care that NCLEX tends to ask about a lot. If you're currently taking endocrine in school, you're going to see this on the test. So make sure you know it. You're going to teach a patient to inspect their feet at least once a day. If they can't physically bend over to inspect their feet, doing it that way, tell them to use, sorry guys, my nose is running, I'm sorry, my allergies, forgive me. Tell them to use a mirror or have a family member or someone that they trust inspect their feet every day. Tell them to wear proper fitting shoes. They can't wear shoes that are too big because what happens is, let's say this is a shoe and this is a foot, right? If it's too big, their feet will constantly slide back and forth in the shoe. And that friction can be enough to finally cause an opening in their skin. It'll decrease the integrity of the skin. And what are we worried about? Infection. So they can't wear shoes that are too big, but they can't wear shoes that are too small either, because if the shoes are too small, that could cause them to have hardened areas on the skin. What are those things called? I'm calling them bunions, but that's not the word I'm looking for. But anyways, it can cause that, and that will also decrease integrity of the skin. Bacteria can open up. We don't want that to happen. So they have to wear well-fitting shoes. We're going to teach them to wear cotton socks that are absorbent, right? To keep their feet dry, clean and dry. So after they take a shower, it's very important to dry between the toes, because what happens is between the toes, if it stays wet, that fluid that's sitting there on the skin can eventually cause maceration, and guess what? Decrease skin integrity. Bacteria can start before you know it, the patient has an infection, right? We're going to teach the patient to wear what's what I'm looking to wear correct fitting shoes, but proper shoes. So like they could wear sneakers, shoes that will cover their feet. They cannot wear thongs. You know, the sandals that have that one thing between the two toes, they can't wear that, because what happens is as they're walking, right, that thong will keep rubbing between the two toes, and that can cause an opening in the skin, a decrease in that skin integrity. What else do we teach a patient? We teach them that they need to be clipping their toenails. And guys, yes, they need to see their podiatrist often. They need to go see a podiatrist about every 2-3 months. But you think the only time they cut the toenails when they see the podiatrist? No. They need to be trimming those toenails weekly. And if they can't do it, they'll have a family member do it for them. But it's very important. And so what you do is teach them to clip straight across, okay? File straight across. Now the patient's going to do that to their feet. You as the nurse, are you going to clip a diabetic's toenails? Absolutely not. You're going to refer them to go to the podiatrist. But for them, when they're caring for themselves at home, you teach them that, okay? Straight across, never on the edges. What else? Socks. Keep the feet clean and dry. Well-fitting shoes. Use a mirror, inspect the feet daily. It'll come to me with some more. But anyway, diabetic foot care is very important. Prevent injury. Next, infections and wounds should receive meticulous care. Absolutely. That tiny little wound on the foot can turn into a necrotic foot that ends up having to be amputated. So it's very important. Foot care. Oh, this was on the list and I was over here racking my brain. Okay, so feet should be kept dry. I talked to you guys about that. Footwear should always be worn. Wear cotton socks. We talked about that. Should not wear tight-fitting shoes. Yes, I talked to you guys about that. Okay, that's all they had to say. But the extras that I talked to you guys about, make sure you know that as well. If you're currently in the nursing program, you'll see that on test somewhere. Let's talk about sick day. When patients with diabetes mellitus become ill, glucose levels become elevated. That is absolutely true. And NCLEX also wants you to know that if a patient, here's a situation they'll give you. They'll tell you that the patient is no diabetic. They're in the hospital for whatever type of, no. I'm backing up. I'm lying. That's not how the question goes. They'll tell you that a patient who's not known to be a diabetic, they're not known to be a diabetic, they're come to the hospital for surgery. I forget what kind of surgery, whatever the type of surgery is. And wait, guys, I'm having a brain fart. That is not how it goes. Give me a second. I'm going to tell you because this is a famous question on NCLEX. Let me back up. The patient's a known diabetic, but they're only on oral hypoglycemics, okay? It's a known diabetic that's only on oral hypoglycemics. They're in the hospital for surgery. I forget what type of surgery they're in the hospital for. However, you come into the room and they're in tears. They're crying because they have to take insulin. And they say, you know, I've been working so hard to keep my glucose under control, and now, you know, I'm insulin dependent. I have to keep giving myself shots for the rest of my life. What do? You educate the patient. You let them know that during times of stress, physical stress, such as being sick, emotional stress, psychological stress, blood sugar goes up. Remember, fight or flight. Your blood sugar goes up because your body needs that energy to fight the infection or fight whatever it is that's stressing you out or get the heck out of here, right? So it's temporary. But as soon as you're better, the blood sugar should go down. So you tell that patient that just because they're on insulin now, because obviously they're having a physical stress, it doesn't mean that they're going to be dependent on insulin for the rest of their lives. That is very important for you guys to know, okay? So anyway, sick day. You need to understand that when patients with diabetes mellitus become ill, the glucose levels become elevated, okay? So during times that the patient's sick, they may need a little bit more insulin than normal. Now, they're not going to self-prescribe. They need to let their doctor know that they're sick, and the doctor will prescribe, you know, make the changes that are necessary. So you're going to teach them to continue to check their blood sugars and do not withhold insulin. If anything, they would need more insulin during that time of elevated blood glucose. And you're going to tell them to monitor their ketones for urine. Because let me tell you something. If that patient's spilling out ketones, you know their blood sugar is excessively high and they need to call the doctor right away. Let's talk about the 15 rule. If the blood sugar is low, you're going to give them a 15-gram carb, like 5 lifesavers, 6 ounces of orange juice, then recheck in 15 minutes. So that's where the 15 minutes come from. So guys, you are going to give them simple sugar. You're going to give them something to make their blood sugar go up immediately, such as the orange juice or some lifesavers. But let's talk about the lifesavers. Let's talk about the orange juice. If that patient's blood sugar is low and they're passed out, are you going to give them lifesaver orange juice? Absolutely not. They're going to aspirate. You're not going to put anything in their mouth if they're passed out, right? So they have to be awake, alert, like they have to be able to swallow for you to give them the sugar. All right, let's talk about complications of diabetes. Lipoatrophy, that's loss of sub-Q fat at injection site. And so what happens is the patient who's getting insulin, they're giving themselves these injections several times a day. if they're not rotating the injection sites and they're giving themselves injection in the same place, what happens is that same place they keep giving themselves injection, that subcutaneous fat, it gets hard. It gets hard as a rock. And so what happens is when it gets hard as a rock, the absorption of the insulin is decreased, which makes the effectiveness of that insulin decrease. And that's why you teach a patient to alternate sites. And you're going to teach them, don't alternate sites like left arm, then right arm, then left stomach, then right. No, rotate sites in one area, then rotate sites in another area, then rotate sites in another area. That's how you teach them to rotate sites, okay? Let's talk about Dawn phenomenon versus samoji phenomenon, or samoji effect. Most of the book call it samoji effect. So Dawn phenomenon, we're going to see the patient hypoglycemic around 5 to 8 o'clock in the morning. How do we help with this? Evening administration of insulin, giving them insulin in the evening. You're going to adjust the diet, give them a bedtime snack. That's a biggie, right? Insulin dose, exercise to prevent that early morning hyperglycemia. Adjust, do not eliminate. What does that say? Usually intermediate acting insulin is used. Excuse me. I just have a brain fart, guys. Give me a second. I gotta think about what I just said and what I'm about to say to you guys. So Dawn phenomenon, reduced insulin sensitivity. So excuse me, guys. I think I just told you that the blood sugar is low, the blood sugar is high at this time because there's reduced insulin sensitivity. So we see the blood sugar actually high, around 5 to 8 in the morning. Now here's the problem with this. I'm going to explain to you. So the nurse sees that blood sugar is high between 5 to 8 when they check. What do? They give that patient more insulin. But the problem was the patient had insulin or high dose or more than they needed to that night before. And so the body reacts from that insulin of that blood sugar being low to now being high between 5 to 8 o'clock in the morning. The nurse, who doesn't know, checks the blood sugar between that time, sees that the blood sugar is high, and gives the patient more insulin. And insulin is what caused this problem to begin with. And that's why, if you take a look, let me show you where I am right now. That's why it says bedtime snack. So let me recap, because you guys have to understand this concept. With Dawn phenomenon, we're going to see the patient's blood sugar high between 5 to 8 in the morning. But the reason we're seeing that is because that night before, the insulin that they got was a little bit too high, too much, which meant their blood sugar would become too low around that 5 to 8. And the nurse who checks has no clue. All they see is that sugar's low. That sugar's high, and what do? They give the patient more insulin, and that insulin that they got the night before is what caused this whole problem. So a solution to this is what? Bedtime snack and adjusting the insulin dose. And you're not going to adjust the dose, the endocrinologist or the physician will. And what they're going to do is give a lower dose. They're going to give a lower dose of insulin, plus that patient's going to get a snack at bedtime, and it's going to help that blood sugar not to be so high between 5 and 8 in the morning. Okay, that is your Dawn phenomenon. Now let's switch gears to samoji effect. Samoji effect is nighttime hypoglycemia that results in rebound hyperglycemia. Same thing in the morning hours. Okay, and this is later in the morning. Most books actually for Dawn phenomenon, they really give you about 4 to 7. This is saying 5 to 8. But anyway, with the samoji, it's later in the morning. I would say like around 9 or so. But it's the same concept. Okay. Now let's talk about insulins. Oh my gosh, guys, there is no way. I have no mnemonic to give you to memorize these insulins. The only thing I can tell you is to make drug cards, because make drug cards. Index cards, you have to know these insulins. There's no way around it. But here's what I can tell you after you've memorized these insulins. You see here where it says onset, where it says peak, and where it says duration. These are your key to so many questions. I'm going to explain in a second. Whenever you get a test question telling you that the patient's diabetic, you're about to give them insulin, when are you going to feed the patient? What they're really asking you is what is the onset of this insulin? So you need to know the onset of regular insulin is 30 to 60 minutes. Why do you need to know that? Because if that insulin starts working within 30 to 60 minutes of it being given, guess what you better have in front of that patient within that time? Food, because we want to avoid a hypoglycemic reaction. Let's say peak. Let's talk about peak. They tell you that you just gave NPH, insulin, right? And they tell you it's now 4 or 5 hours later. What are you going to assess for? Or let me reword it. You just gave that patient NPH insulin. When are you going to assess them, or when is the most critical time, or when are they at most risk for a hypoglycemic reaction? Whenever they ask you that, what they're really asking you is what is the peak time of that insulin you just gave, because they expect you to understand the peak of insulin is when that patient's blood sugar is going to be the lowest. That's when they're at the highest risk of bottoming out of having a hypoglycemic reaction. Okay? Let's talk about duration. So, for example, they'll tell you you just gave insulin Detmir, and they ask you, when do you expect to give the next dose? What they're really asking you is what is the duration of insulin? Because you're not going to give the next dose until the end of that duration, at the end of that 10, 11 hours, right? So depending on how that question's worded, you'll know what they're asking. If they're asking you when you plan on having that food around, they're really asking you about the onset. When they ask you when are you going to monitor that patient most closely, when are you going to reassess them, what's the most dangerous time for them, they're really asking you about the peak of that insulin. And when they ask you when you plan on giving that next dose, what they're really asking you about is the duration time of that insulin. Rapid acting, absolutely. Look at this. Rapid acting insulin should only, guys, you know how I feel about only. Whenever you're studying, whenever you're reading and you see only, always, never, you know that you need to know this information. This is the only, it should only, be given if food is available and the patient's ready to eat. God forbid you gave a rapid acting insulin to a patient and that food tray's not there yet, and the person who is delivering the food got caught up in something. Your patient's bottoming out because you gave them that insulin, which is dropping their blood sugar, and they don't have anything in their system. Okay, so I promise you guys, you better know this. With rapid active insulin, you better not give it to the patient unless you visually see that food in front of them and that patient's ready to eat. Okay. Types of insulin: onset, peak, and duration. Talked about that. All right, let's talk about drawing up regular insulin. So guys, when you're drawing up regular insulin and NPH, it's clear to cloudy, okay? Or another way to think about it is RN. R is for your regular and N is for NPH. So the regular comes before NPH. So let's talk about how you're going to draw it up if you're giving them together. So remember, clear before cloudy. Clear before cloudy. So you're going to give the regular, drop the regular first before you drop the NPH. But remember, you have to create that vacuum in each. So here's how you do it. Take a look at this, guys. Even though it's clear to cloudy, you're going to put air into the cloudy first, right? You're going to put air in the cloudy first, and then you're going to put air in your clear. And after you put air in your clear, because you've created that vacuum, then you pull your clear first. Then go back to your cloudy and pull your cloudy to give. Do you understand? So you're going to pull your clear before your cloudy, but because you have to create that vacuum, you're going to put air in the cloudy first, then go to your clear, put air in the clear, draw up your clear, then draw up your cloudy. All right? Moving on. Hyperglycemia requires urgent treatment. Absolutely. Because guys, when you, hypoglycemia requires urgent treatment. When your blood sugar is high, we talked about this. Well, I talked about this already. Your body tries to survive. So you start having polyuria, polydipsia, polyphagia. All of these are trying to help you, right? But there's not much that your body can do if you're having a hypoglycemic reaction. One moment, the patient's confused and boom, they're on the floor, okay? So this is urgent and the patient needs treatment. Again, let me go over those signs and symptoms. The patient's gonna be hungry or hangry. They're gonna be irritable. They may be weak, headache. Blood glucose is gonna be less than 60. Remember, normal is what? 70 to 110. Again, 15 rule, you're gonna give them 15 grams of carb, recheck them in 15 minutes. Glucose should be retested in 15 minutes. The patient should eat a small snack of carb and protein if the next meal is more than an hour away. And here's why carb and protein. So that carb is gonna bring up the blood glucose, but then that patient can crash, right? That protein is gonna keep it at a sustainable level, okay? You're going to repeat carbohydrate treatment if the symptoms do not resolve. Alcohol. Alcohol has the potential for causing alcohol-induced hypoglycemia. It's important to know when the patient drinks alcohol and to teach the patient to ingest it shortly after meals to prevent this complication. Very important. Preferably they don't drink, but if they do, that's a very important teaching for them, guys. So guidelines for exercise are based on blood glucose and urine ketone levels. Remember, guys, they need to check their blood sugar before, during, and after exercise. When ketones are present, the patient should not exercise because it indicates that current insulin levels are not adequate. And that's important for you to know because patients will think, well, if I'm spilling ketones, that means my blood sugar is too high. Let me go exercise and try to bring down my blood sugar. No, that patient's not stable. You teach them if they are spilling ketones under no circumstances should they exercise. That is a very important rule. Guys, diabetes is huge, and I'm not going to rush this. So I'm going to stop here, and I'll try to do another video continuing this with diabetic ketoacidosis. But guys, there's so much in diabetes you have to know. So I hope this was helpful for you. I hope it cleared some things up. I hope it makes more sense to you when you go back into your textbook and you read about it. It kind of all comes together because this is stuff you have to know. And this is regardless of whatever state you're living in that you're going to be testing for. Excuse me. Because diabetes is so prevalent. So it doesn't matter what state you're in, they're going to kill you with diabetes questions. So you have to know diabetes like the back of your hand. As always, guys, please let me know what you think about this video. Please let me know what you'd like me to cover next. This is new because usually, guys, you know me, I cover questions. That's my specialty. I teach you how to answer questions. But I'm really thinking of maybe starting a teaching series where I just go over just important things for you to know so you can kind of have the best of both worlds. So if you think that's a good idea, let me know in the comments. If you think that's a horrible idea and I just need to stick to questions, let me know in the comments as well. I want to know what you think, and I'm trying to decide which direction to go. So I'd really love to hear from you. Thank you so much for watching this video, and you guys will be seeing me next time.